Assalamu alaikum. Today we're going to talk about anatomy and premalignant conditions of oral cavity. Oral cavity is conveniently divided by the arch formed by the teeth and gums into oral vestibule and oral cavity proper. Oral vestibule lies between the gums, teeth, inner lips and inner cheeks, while oral cavity proper lies behind and within the arch of teeth. Oral vestibule bounded anteriorly by the lips, laterally by the cheek, superiorly by the mucolabial and mucobuccal folds, and posteriorly and medially by the teeth and gums. While oral cavity proper is bounded anteriorly and laterally by the teeth and gums, superiorly by hard and soft palate, inferiorly by the tongue and the floor of the mouth, while posteriorly by opening into the pharynx. Mouth have a rich blood supply by getting branches from different arteries like facial arteries, inferior alveolar artery, maxillary artery, infraorbital artery, posterior superior alveolar artery. While lymphatic drainage from submental, submandibular, jugular-digastric, superficial and deep cervical system drain ultimately into internal jugular lymphatic system. Now we discuss about precancerous lesion and conditions. Precancerous lesion, they are morphologically altered tissue in which cancer is more likely to occur than in its apparently normal counterpart. While precancerous conditions generalize its generalized state of a body which is associated with a significantly increased risk of cancer. Premalignant lesions can be classified into high risk, medium risk and low risk. While in high risk there is erythroplakia, proliferative, verrucous, leukoplakia, chronic, hyperplastic, candidiasis. In medium risk group there is oral submucous fibrosis and syphilitic glossitis. While in low risk there is oral lichen planus, discoid lupus erythematosus and discoid keratosis congenita. Now we talk about leukoplakia. This term leukoplakia was first coined by a Hungarian dermatologist in 1877, while the word arises from two Greek words, that's leukos, that mean white, and plakia mean patch. According to WHO, that defined leukoplakia in 1978, that it's a white patch or plaque in the oral cavity which cannot be scraped off or stripped off easily, and moreover which cannot be characterized clinically or pathologically as any other disease. It represents 85% of all oral precancerous lesion. This incidence is around 3 to 4% in adult population and usually occurs between 4 to 6 decades of life. It have male preponderance with the trend changing gradually. Its etiological factors include tobacco and alcohol consumptions, areca nuts, that's pan masala, poor nutrition, inherited condition like Fanconi anemia and Lieberman syndrome. While viral infection like human papillomavirus can also be a etiological factor. Classification of leukoplakia could be based on its clinical type like homogeneous and non-homogeneous, as etiological factors like associated with tobacco or idiopathic, could be on the basis of extent, that's localized or diffuse, or could be based on risk of molecular transformation and on the basis of its site and histological type. Clinically, it can present as solitary or multiple white patches, varies from a non-palpable, faintly translucent white area to a thick fissured papillomatous or indurated lesion. 70% are in buccal mucosa, commissural area, followed by lower lip, floor of the mouth, palate and gingiva. Symptoms include feeling of increased thickness of mucosa, while in case of ulcerated or nodular type, it could present as burning sensation. Patient might present with enlarged cervical lymph node in cases of metastasis. This management include either conservative management that includes elimination of etiological factors, restraining from smoking or chewing tobacco to remove sharp broken down teeth, correction and replacement of overhanging or faulty metal restoration with a metal bridge, while in chemoprevention, isoretinone, beta-carotene, topical bleomycin or 5-fluorouracil along with cisplatin can be used. If the lesion is more than 1 centimeter in size, then either surgical stripping with the help of scalpel or cryosurgery with liquid nitrogen, electrocautery or laser ablation can be employed. The second lesion is erythroplakia. According to WHO, any lesion of the oral mucosa that present as a bright red velvety patch or a plaque which cannot be characterized clinically or pathologically as any other recognizable condition. Its clinical variant includes homogeneous erythroplakia or erythroplakia interspersed with patches of leukoplakia, granular or speckled erythroplakia. Its etiology is the same as for oral leukoplakia. It involves mainly middle age and the peak incidence is between 65 to 75 years of age. Again, is mostly involving the male population. While if you talk about the location, mostly is occur over the soft palate, floor of the mouth and buccal mucosa and over the tongue as well. Typical lesions usually they are less than 1.5 centimeter in diameter, but lesion greater than 4 centimeter has also been observed. As typical features are that most of the time is smooth and granular or sometimes nodular well-defined lesion, may have an irregular red granular surface interspersed with white or yellow patches, soft on palpation. They have higher risk for malignant transformation that's ranging from 14 to 50%, based on the fact that on histology 80 to 90% of cases present as carcinoma in situ, severe epithelial dysplasia or as microinvasive carcinoma. Its management include confirmation by biopsy, and treatment would be guided by histological diagnosis. Recurrence and multifocality is common, so careful long-term follow-up is required. Chronic hyperplastic candidiasis. It produces dense plaque of leukoplakia, particularly around the commissures of the mouth. The lesion occasionally extend on to the vermilion and even the facial skin. High incidence of malignant transformation thought to be the result of invasion of the lesion by Candida albicans. Specific management of chronic hyperplastic candidiasis includes prolonged topical antifungal treatment or systemic antifungal treatment that comprises of 2 weeks. If the lesion persists after medical therapy, particularly when dysplasia is evident on biopsy, then surgical excision should be considered. Oral submucous fibrosis. In oral submucous fibrosis is a progressive disease in which fibrous bands form beneath the oral mucosa. Scarring produces contracture resulting in limited mouth opening and restricted tongue movement. It's almost entirely confined to the Asian population, characterized pathologically by epithelial fibrosis with associated atrophy and hyperplasia of the overlying epithelium. The epithelium also shows changes of epithelial dysplasia. Its management include a device for restricted mouth opening and use of intralesional steroid, surgical excision or release, along with reconstruction may lead to short-term benefit only for fibrospans to reoccur at the same site or progress at other sites. Prevention, it would include cessation of usage of pan masala with or without alcohol may halt the process but not necessarily leads to improvement. The next condition is SIDEROPENIC dysphagia, that's also known as PLUMMER VINSON and PATERSON-KELLY syndrome. There is a well-known relationship between sideropenia, that's iron deficiency anemia in the absence of anemia, and the development of oral cancer. Common in Scandinavian women, leads to epithelial atrophy which render the oral mucosa vulnerable to irritation from topical carcinogens. Treatment include correction of sideropenia with iron supplements, reduces the epithelial atrophy and risk of malignant transformation. Thank you very much for your attention. If you have any question, you can ask in the comments below. Have a good day.